Hello and welcome. I'm Autumn Lafretta at the Foundation. Thank you for joining our Answers from the Experts Q&A. We're very excited to have you here today. Before I introduce our panelists, I'd like to go over some housekeeping. Q&A. Please add your questions to the Q&A tool in Zoom. We will be recording this and the video will be available on the Foundation's YouTube channel in a few days. Upon conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. We would like to thank our individual donors and our funding partners for making programs like this possible. Now, I would like to share some information on our speakers for today. With us today, we have Dr. Pacheco, who is a professor of dermatology at the University of Colorado, and Dr. Haverkos, who is an associate professor of medicine hematology, University of Colorado. Let's go ahead and get started. Welcome, Dr. Pacheco and Dr. Haverkos. Thank you for being here today. Before we take our first question, a reminder that the doctors are not giving second opinions. They are sharing their knowledge based on their experiences. So let's go ahead with our first question. How do I control the itching?
That's a great question and a common question that our patients ask us every time we see them in clinic. If they have itching, they can be quite miserable because of it. And so really the best way to control the itching is to get on the right therapy. So if you're on the right therapy, the itching from your disease will go away. So that is always our goal. Secondarily, we often will use things like antihistamines to control the itch, gabapentin to control the itch, phototherapy to control the itch, or even photopheresis to control the itch. But at the end of the day, it's finding the right treatment that will control your disease.
Thank you so much. Our next question, I'm interested to know if there is any new treatments for Sezary peripheral T-cell lymphoma. My father will begin soon on MOGA.
Yeah, that's a good question. Good question as well. There are some new treatments that are coming out. You can always look on clinicaltrials.gov to look for clinical trials that are open and available. MOGA or mogamulizumab is a very effective treatment often for Sezary syndrome. So it's of course probably the right treatment to start with, but there are some new developments that if perhaps mogamulizumab doesn't work or doesn't work to the satisfaction that you might like, there's some new developments, new drugs, also we're learning how to maybe combine MOGA with other therapies as well. So there's a lot of room to be optimistic about MOGA working as a starting place, but also even if it doesn't work, there are some opportunities to maybe think about how we can add to that or perhaps other therapies that might come about in the next couple of years, might be FDA approved.
Thank you. How frequently should I use light therapy and for how long? Dr. Pacheco?
Yeah, so phototherapy is used often in early stage disease alone, so as a monotherapy to control disease. So in those cases, the primary goal is always to start therapy and to clear the disease, put the skin in remission. And then the question is, what do you do next? Do you stop therapy or do you continue it? And I think if you go to different cutaneous lymphoma centers around the country, they're going to have different philosophies. The philosophy that I often use with my patients is that once they're clear on phototherapy, I recommend a very slow taper. So instead of phototherapy twice a week, we go to once a week, and once every 2 weeks, once a month, and you can eventually taper to one treatment every 3 months, which is 4 times a year as a maintenance forever. That being the case, there are other cutaneous lymphoma centers and other doctors that have different philosophies in which they will clear the disease and then stop phototherapy.
Yeah, this will probably tie in with some other questions, but we always think about any therapy, whether it's skin directed or whether it's a systemic therapy, we're always tailoring that therapy to the individual patient. And some people have great responses to single agent phototherapy, for example. and may, for whatever reason, may want to take a break from therapy. And so it's just a discussion between, your medical team and or discussion with your medical team to try to figure out what makes the most sense for you and your lifestyle and how your disease is responding or not responding, and how symptomatic you are from your disease. So I think it's just an ongoing discussion that we always have with patients, trying to individualize therapy based on needs and wants.
Thank you both for that. It was a great answer. I have MF. Does this raise the risk factor for other types of cancer?
Yes, good question. There is a slight increase in other, mainly lymphomas, in people that have mycosis fungoides. We often also see, so that's other non-Hodgkin lymphomas. The risk of that is slightly higher as compared to the general population. In addition, we often will see a uh, non-cancerous skin condition called lymphomatoid papulosis that not uncommonly can coexist with mycosis fungoides. So it's it's a somewhat, I wouldn't say common, but it happens in our clinic, not on an insignificant number, where we see people with mycosis fungoides and lymphomatoid papulosis. And it kind of goes to the point too that we always think about repeat skin biopsies in our patients if the skin lesion perhaps is different than it was before, and also helps guide therapy in some ways. So it's important to always kind of keep an eye out for these new skin lesions that come up, about whether it makes sense to do a repeat skin biopsy to see if it's a different entity like lymphomatoid papulosis, which responds to different treatment, or perhaps changes in the mycosis fungoides cancer cells that may dictate a different treatment.
Right, thank you. I have MF for about 5 years. I have come to the conclusion that I have an eruption after a major health event. Is this normal, common for those plagued with this version or other forms of cutaneous lymphoma?
That's a hard question, but I think the best way to answer it is that a major life event usually is a stressor. So, and stress can contribute to disease. And we have seen in our patient population that their disease worsen after a major life event or health event, which is a stressor. So stress can contribute to disease. It doesn't cause it, but it does contribute. I hope that answers the question. Brad, do you have any other suggestions or ideas?
Yeah, no, I was just going to add that, we commonly see patients where the disease can kind of wax and wane a bit. Both the lesions can fluctuate and sort of how angry they may look, or how red they may look, or how bothersome. Some of that can be something as we'll see patients that live in Colorado and then move to a more humid environment, for example, and we'll see patients that have different. Their disease may feel different to them or look different to them depending on the climate. Is a common thing that we run into, but certainly stressors, certainly other things like hot showers and things like that's going to sometimes bring out the disease a little bit. And so there's a lot of environmental triggers or stressors, like Dr. Pacheco is saying, that can bring about the disease. Another one that we commonly or somewhat commonly run into is if patients get infections, for example, or the lesions can sometimes get super infected, and that's going to make it look different than otherwise would. And so this pattern of sort of kind of fluctuation in the disease that is not necessarily the disease going away or getting better, but just changing because of these external variables. And so, just kind of important to keep that in mind, I guess.
All right, thank you. I have noticed that the patches in my sanctuary sites, groin and vulva, seem to improve during the summer months with no specific changes to the treatment I do with a handheld UVB wand or my full body treatments. My assumption is that a lesion will only improve by direct UVB exposure. Are areas that are not exposed during full body treatment impacted anyway?
I can answer
Have you
that
had any
question.
in your experience? Great, thank you.
Yeah, no, I can answer that question. So I'm gonna kind of go back to just regular dermatology. So we use phototherapy all the time for psoriasis, for vitiligo, for itch, for just dermatitis. There was a study done in the 1980s for itch, and they treated a patient that had whole body itching everywhere on their body. And they put the patient into like a bodysuit on one half of their body. So the other half was exposed to the phototherapy light in the booth. But the other side was blocked because they were wearing clothing that blocked the UV light. What they learned during that, case series is that the itch improved all over. And I guess maybe the best way to think about it is cutaneous T-cell lymphoma, mycosis fungoides type, is a lymphoma. So it is a blood cancer. The lymphocytes, which typically should be circulating in the blood and the lymphatics, are sitting in the skin causing this rash. But, it's very likely that they're circulating as they should in the lymphatic system and in the blood system. And so I'll see if Brett has anything else to add on that.
No, I think that's a great answer. And maybe also goes back to kind of what I was insinuating before, is that sometimes just based on the environment, whether it's a more humid environment or not, may have an impact on kind of how bothersome the skin lesions are, how itchy they are, in a very hot or humid. You can imagine that that area may get a little bit more irritated. And certainly we see other things like bacterial or fungal overgrowth sometimes in certain areas, especially kind of like the axilla or groin areas. Sometimes just colonization of bacteria or fungal or fungus, which typically normally just live on our skin anyway, can kind of drive or put sort of charge up those lesions. And it's quite common that we'll treat patients with antibacterials or antifungals for a period of time, and it just helps the lesions get better on their own.
Okay, thank you. For Sezary patients, how do you know when you should seek immediate medical attention for something that might be related to the cancer? For example, since we're at risk for sepsis due to compromised skin barrier, should we watch for symptoms of possible sepsis?
Yeah, I'll start, I guess, answering this question. It's a tough one to give too many specifics because I think everybody's a little bit unique. But we always try to have kind of open line of communication with our patients so that if something is out of the ordinary, that we like for the patients to be able to contact us and let us know what's going on. I mean, of course, very concerning symptoms like high fevers, chills, low blood pressure, feeling lightheaded or dizzy, feeling very unwell, should prompt you to go right to an emergency room or at least call the triage line and have them direct you. Uh, but I guess, if patients with a compromised skin barrier, like Sezary patients, like other cutaneous T-cell lymphoma patients, we do worry about an infection coming from the skin into the bloodstream. Often that can start with something just like an infection in the skin or cellulitis. And so I think if your skin is sort of breaking down, ulcerating, crust, sort of having some crust or discharge from it, it's definitely a good thing to alert your team about this change in the skin lesion. I really And they may want to intervene with some antibiotics earlier as opposed to waiting till it becomes something that's more severe like sepsis. Uh, but I don't know if you have other thoughts, Dr. Pacheco, or wanted to add anything to that.
No, I think I would just add that it doesn't only have to be the Sezary patient. Patients with plaques and patches and definitely tumors have a compromised skin barrier because of the lesions, and all are at risk for the secondary infections of, viruses, which are rare, fungus or yeast, which is medium, but then also probably more common bacterial infections. So that's the only thing I would add, Brad.
Hmm. Yep.
All right. This one can be a little bit tough. I had one doctor tell me that treatments do not change any long-term outcomes, and I had another tell me that it does make a difference in outcomes. So, in overall treatment, like how are you making decisions? Maybe I'm not really sure if it's the decisions, but your
Yeah.
experience of the treatments that are working. And I think one of the things that we know with a lot of times treating cutaneous lymphoma is improving your quality of life.
Hmm.
So what is how are treatments impacting outcome?
Yeah, I guess I'll start try to answer that. But we really approach cutaneous T-cell lymphoma, mycosis fungoides subtype, based with a stage-based treatment approach. So earlier stage patients, with just skin, mainly patches, sometimes plaques, we'll start with skin-directed therapy. And then patients with more aggressive disease, whether that be clinically more aggressive or ulcerating lesions or tumors or blood involvement, we'll tend to start with more systemic therapy or systemic therapy in addition to skin-directed therapy. Um, and so, but in the context of treating people based on a stage-based approach, we also, individualize therapy. And our goal of all therapies is to improve quality of life, and improve the symptoms. So to one of the first questions we got was, how do we fix the itch? You fix the itch by treating the underlying disease. And so I would say fixing the itch or improving the itch is an important outcome that we want to improve. Just like if you have many skin lesions that are bothersome to you, I think getting rid of those lesions is improving an outcome and improving your quality of life. We think it's really important to assess patient-reported outcomes, meaning that things that matter to patients, we want to try to make those things better, like the itch and like how the skin lesions look. We do have some people that the skin lesions are not that itchy and sometimes not that bothersome to them, and they don't want to do treatment or don't want any treatment, even don't even want skin-directed therapy like phototherapy. And I think to that type of patient, I think it's okay to say that, we don't necessarily have clear data that shows that intervening in an asymptomatic patient has a clear, measurable, will clearly, modify their disease moving forward. But most people in this with the have cutaneous T-cell lymphoma are bothered by it and have symptoms from it. And I would say improving those symptoms is an important outcome.
And the only thing that I'll add is probably 18 months ago, Dr. Haverkos and I, in collaboration with another oncologist at the University of Colorado, included a questionnaire with each patient visit that, asked, how bad is the itch affecting your quality of life? And we have still yet to do the research and follow up on those data points. But we do peek at the questionnaire when we walk into the room to see the patient, because the patient may look great and have no skin lesions. And we may assume that they're great, but if you peek at the questionnaire, maybe they do have itch and, that's just not manifesting and they're not telling you about it at that point in time because they want to talk to you about something else. So outcomes are many things. And I think our questionnaire is going to help us be better doctors in assessing that.
All right, great. That was really great. Before we ask this question, I'm going to do the reminder that the doctors are going to answer this based on their experience if they have had experience with children or young adults. Would a child in an early stage of MF be a good candidate for UVB phototherapy? What are the benefits and the risks?
So I can say Brad and I are allowed to only see patients 13 and above. So we do see patients that are 13, 14, 15, 16, 18 that, are considered pediatric patients with this disease. And we often use phototherapy just like we would in an adult patient. I don't know, Brad, if you want to have anything else to add on that.
No, I mean it kind of goes back, I guess, to the last question too. If our therapies are important to the long term, to or the change, modifying the disease, or changing the disease or decreasing the risk of progression down the road. Even though we don't have clear data, I think it's probably better to have less skin lesions than more skin lesions, not only from a symptomatic standpoint, but sort of biologically, it just makes sense that having less of these lymphoma lesions is probably going to make you less likely to have progressive or transform disease, although we still don't have objective data to support that statement. So take it with a grain of salt. So often we do like to treat people that have skin lesions, regardless of age.
Okay, thank you so much. Our next question are what are the names of some mild cortisone creams for stage 1B mycosis fungoides?
So I can answer this question. We use topical steroids in dermatology all the time, and they're grouped 1 through 7, 1 being the most potent and 7 being the least potent. 7 you can buy at the drugstore. So, over-the-counter Cordaid or a topical hydrocortisone is a group 1. The ones we use to treat early stage disease, stage 1, A or B, usually would be group 5s, and I think a common one would be triamcinolone, fluocinolone. But there's a table, and I think with the ability to use the internet, this would be a good use of that, or AI things to say, what are the 7 groups of steroids and what are the generic names for them or the common names for them?
Okay, um, this is an interesting one as I have a great dermatologist,
Good
oncologist,
start.
and radiology oncologist. Would you recommend contacting a hematologist in addition to my medical team?
I mean, most oncologists have some hematology training. I think if you're with an oncologist that feels comfortable managing cutaneous T-cell lymphoma, I wouldn't seek out a hematologist unless there's a specific, hematology question per se. So, um, yeah, it's hard to give exact specifics, but probably not is the answer.
All right. When will I know if the phototherapy is working, if all the patches still look the same? I just finished dose 8, and they're doing week 4 of 3 days per week.
All right. So, in our experience with phototherapy patients, I like to caution the patient at the beginning slow and steady wins the race. And so, I often won't see patients until the 4 to 6 month mark after starting phototherapy because it does take that long for skin to improve on the therapy. Interestingly, though, disease can worsen early on while starting therapy because the phototherapy brings out disease. So you're whoever asked this question, you're barely in to your phototherapy course. I would just be reminded of the slow and steady wins the race course and continue your treatment. And then meet with your doctor at the 4 to 6 month mark to decide if you continue or you switch courses.
Yeah, and I'm sure Dr. Pacheco will echo this, but it sometimes we see that the things like light therapy or other therapies can bring some disease out, or you can get kind of like a flare at the start of treatment. So, much too early to give up on it. And sometimes we think it might even be a good thing to have some flare of your disease with a treatment. For example, in immunotherapies, sometimes we think that the patients that get some rash from the immunotherapy might actually be the ones that are responding well to it. And so I think early on, we'll often see that the rash will get a little bit worse before it gets better. And so it is important to really stick with it and not be too alarmed. Of course, you want to let your team know. There are certainly examples where therapies don't work. And so I think it's good to not just continue on forever, but I think at least in the early stages, it's important to give therapies a good shot at working and not be too alarmed if you're getting a bit of a worse rash initially or new spots even.
All right, great. Is it still clinically believed that follicular MS is a more aggressive variant, or is that outdated based on new research? Dr. Haverkos?
Yeah, I think there are certainly cases of folliculotropic mycosis fungoides that don't do particularly well or have a more aggressive course. But there are lots of patients with follicular tropic mycosis fungoides who do very well. And I think more we've really come to appreciate that maybe the older data that's out there is not accurate, that it's overall a more aggressive disease. I think when we see follicular tropic mycosis fungoides, maybe we follow a little bit closer along initially to make sure that that it is still an indolent course that we're having. But by no means just having follicular tropic MF means that that you're gonna do poorly, and really that is some older data that's probably outdated.
Okay, thank you. As usual, phototherapy is the topic of the hour. We always get a lot of questions on that. We have a few more coming up. I have stage 2B MF and have an appointment with a radiologist oncologist. I'm also interested in phototherapy. Is it best to get a plan of radiation before questioning phototherapy? Again, the doctors have not seen your medical record, so this is just going to be based on their experiences.
I can start with this and then we can have Brad jump in. But I think of radiation as skin directed therapy, right? So skin directed therapy is phototherapy. It's also spot radiation. It's also total electron beam radiation. So those are three modalities of, light or energy based treatments that are directed on the skin. And we use them all. Sometimes spot radiation is used specifically for people with bigger tumors because phototherapy is not going to go deep enough into the tissue to treat those. So I'll stop there and let Brad add anything else to the answer.
Yeah, no, I think that's exactly what I would have said. I mean, it sounds like this person has tumor stage disease, stage 2B. And so their lesions are, at least the ones that they're considering radiation for, are probably not lesions that are going to respond to light therapy just because they're a tumor sort of defined as vertical growth. Um, and often we'll see that light therapy is best for patients that really have very flat lesions. And so when you see that they get kind of raised up, they tend to not respond as well to phototherapy and need something like radiation, which penetrates the lesion a bit better and treats it better. That doesn't mean that may just be one particular tumor lesion that is not the most amenable to light therapy, maybe get radiation to that spot, and then continue with light therapy for the rest of the lesions. So, we do know that this is a pretty heterogeneous disease, even within any individual, where we can see some people with a tumor, but then may have just patch disease everywhere else. And so you may need something like spot radiation to that tumor lesion, and then light therapy would treat everywhere else, as opposed to someone that has tumors. So again, sort of more vertical growth, either upper or ulcerated, perhaps. Um, if they have many of those tumor-like lesions, then it might be someone that you'd consider for total skin electron beam radiation, where they're getting radiation uh, everywhere. And so, sort of the theme of all of this is individualizing therapy, not only approaching it based on a stage-based approach, but kind of individualizing it. There's there's a lot of differences even within a single stage that we see. So, some patients with one very early stage 1A may, for example, have a plaque that's sort of not, it's still less than 10% body surface area, but not really amenable uh, to phototherapy. And that may be a lesion that we want to radiate and make go away and then go on with phototherapy. So um, those are just a lot of considerations to think about. I don't know I anything else to follow up on that, Dr. Pacheco?
No, no, but it's a great question and it's one that we deal with every single day. So
Yeah. Mhm.
All right, thank you both. From your experience, are there supplements or lotions that can enhance the benefits of phototherapy?
I can answer this one. So we routinely in our phototherapy unit and routinely advise people who use home phototherapy to apply a thin layer of mineral oil, so baby oil, to the skin prior to light treatment. The reason why we recommend that is sometimes patches or plaques or even, thicker tumor-like lesions have scale. That's the keratin, the stratum corneum that's on the top layer of skin. And so the phototherapy wavelength of light is going to be directed towards the skin, but if it sees the scale, it might kind of bounce off or scatter and not get into the skin. So by using a thin layer of mineral oil to the skin before phototherapy can enhance its benefit. And that's the only lotion that I know that can enhance phototherapy.
All right, thank you. Is lymphomatoid papulosis an immune disorder? And if so, why isn't there an emphasis on bolstering the patient's immune system?
All right, I'm going to start with just what lymphomatoid papulosis is, and then I'm going to transfer this question to Brad from an immune standpoint. So lymphomatoid papulosis is not a skin cancer. It's been reclassified by the staging groups as, just a reactive skin disorder and not a cancer. So, is it a activation of the immune system that's causing these bumps? Maybe, maybe not. We see other skin diseases in dermatology that are reactive from a hyperactive immune system. And I typically have not thought this to be the case, but I'm now going to just transfer this question to Brad because I'm curious to see how he'll answer it.
Yeah, I don't think that it is a blood-based problem. I'm not sure that we should think about it like an immune disorder in the way that we think about other, immunodeficiencies, for example, or other systemic processes. I think this is really a problem that's isolated to the lymphocytes in the skin, at least to the best of my knowledge and the data that exists. We know that this entity is not something that progresses internally. It always stays in the skin. So it is not a systemic, at least internal systemic problem in the way that we think about other immunologic disorders. I think it probably just speaks to something like Dr. Pacheco was saying, that these lymphocytes in the skin are probably reacting to something. Sometimes that could be something like a stressor on the body that may bring it out. But I don't, it's not there's no known sort of underlying immune deficiency or problem with the immune system that I'm aware of, at least.
All right, thank you. This one's a little multi-parter, so if we can leave it up for the docs while they're answering it. I was recently diagnosed with stage 1B mycosis fungoides after consultations with 2 dermatologists. Both confirmed the diagnosis, but noted that my disease expresses a gamma delta T cell phenotype. Is that different from cutaneous gamma delta T cell lymphoma?
Okay, I guess I'll start. It's a good question. Uh, we know that gamma delta mycosis fungoides is a um, entity that does not seem that it has different outcomes compared to its more common counterpart of alpha beta mycosis fungoides. Um, there is an entity called gamma delta T cell lymphoma, which is not mycosis fungoides. It's a different type of cutaneous T cell lymphoma that has much different course, different outcomes, different treatments. So sometimes we it requires some work to exclude that it is a gamma delta T cell lymphoma and that it is just a gamma delta mycosis fungoides variant, in which case we don't think that the gamma delta mycosis fungoides variant has different outcomes compared to its more normal, more common counterpart. So
And
it
the
just,
only thing I would add is, the clinical presentation would probably help in distinguishing between the different types of these gamma delta T cell processes.
Mhm.
Okay, thank you. On our next question is, aside from monitoring stress and supporting the immune system, are there any other lifestyle recommendations you typically suggest to patients with mycosis fungoides, such as diet, supplements, or other supportive measures, in addition to the medical treatments?
This is always a question that we encounter with our patients. We used to have an integrative medicine department and clinic where we could just send patients to them and they would get counseled on diet or supplements that would be of benefit to cancer patients. But we don't have that anymore. Of course, there's many, functional medicine doctors out there that are willing to offer advice. But I think what we've ended up doing is just counseling, eat well, make sure you get enough sleep, and then move your body, which is what any person with or without cancer can do. And Brad, I don't know if you have any other comments on this one.
Yeah, I mean, I don't think there's really good data to say that taking any given one supplement or doing anything specific is really going to change your outcome or how you're feeling. So it's hard because I know patients want to have control and want to do something to make their disease better. Certainly get. There really isn't a specific supplement or something that you can do outside of probably what your doctors are recommending or what information you're getting out there from, Cutaneous Lymphoma Foundation to try to learn more about the disease and learn more about the treatment options. But unfortunately, no clear supplements. I always I think one of the recommendations that I sometimes will give is that I think patients should try to get out there and live their life, not only be healthy and take care of themselves medically, even outside of whatever the cutaneous T-cell lymphoma issues may be causing you to do. But important, I mean, the more I see people kind of forget about their disease, that's usually when I know things are heading in the right direction. And I think people should, we always try to tell people to live their life, to go out there. I mean, the whole reason to treat this disease is so that you can have good quality of life. And, if you're hunkering down and not going out because you're concerned about infection or, um, constantly worrying about the disease, I certainly understand those desires, but it's important to try to get out there and go on vacations and do things. And we're very willing, Dr. Pacheco and I, to try to cater to patients' lifestyles. And if that means, adjusting your treatments so that you can go on a vacation, those things are really important. And I think that, we should sort of help as a medical team working with patients should help try to make those happen for you. I think they help
That was great.
overall.
If you are in early stages of MF, how often would you suggest getting blood work done to check if the T cell clones have spread and expanded in the blood?
That's a good, I'll take this one, I guess. It's a good question as well. I struggle with the answer because I don't think there's good data to say that it uh, there's any clear data to show how often it should be done. And I think you get a wide variety of what people do, even within experts, how often they check. I think that my approach is to check it when I think it will make a difference in how we're going to treat the individual or how if it will affect their improving their outcome or treatment. So I tend to not check it. I think maybe I'm a minimalist in that way, and I think there are other people that check it every 3 months. I think it depends also on if you've ever had the clone that's been identified in blood in the past, that's going to make it more frequent. But if you're the common early stage mycosis fungoides patients, I don't check it unless there is a clinical reason to think that there might be blood involvement. For example, patients aren't responding well, patients have extensive pruritus everywhere, patients are erythrodermic. I think there are clinical scenarios where it makes us think, oh, there might be um, blood involvement. If I find blood involvement, is that going to help? Is that going to make me choose a different treatment? So I think those are the things that I think about how when to check it. And so for me, it's not I'm going to check it every 3 months. I'm going to check it when it's going to impact what I do and trying to make the patient better.
Thank you. Next we have, what are the chances of having two different types of cutaneous lymphoma? Does it mean it is in transition?
Well, I guess I can start, and Dr. Pacheco can jump in too.
I'll let you start. Yeah.
So we do see that it's a little bit more common. I gave the example earlier of a patient with mycosis fungoides, and it's you know, not an uncommon scenario where we'll see that patient also develop lymphomatoid papulosis. That's sort of the most common scenario. Uh, what we also see though is that people with mycosis fungoides, the clinical picture or phenotype of their disease can change a little bit. So individuals could go from a initial presentation looking like a classic Sezary patient with erythroderma, may have blood involvement. They may go on to get MOGA, may have a great response, and then some years down the road may present with more typical kind of early stage mycosis fungoides with kind of patches and plaques. And we may see the reverse. We may see individuals that have a tumor initially that then go on to have patches, and so I think there are the clinical picture can certainly change and look different over time, and that's why it's important that sometimes therapies that may have not worked initially or may have worked initially might not work in the future or the reverse. We do know that certain kind of flavors of the disease respond differently to different therapies. We gave the example earlier of how a patient with a tumor is not someone that's probably going to respond great to light therapy and may need radiation. And so I think there's always going to be changes over time. Of course, ideally, someone would have early stage disease, get light therapy, and stay in remission forever. But many patients have fluctuations in their disease and how it can present can move up to sort of a classic tumor stage disease and then move back down, not have tumors and just typical patches. So uh, I think that's probably what the question was. I hope that answered the question. There's a lot of uh, changes that can happen sort of under the microscope or genetically to the cells as well, but I think probably the more important message to get across is that it can definitely change in terms of how it looks over time. I don't know if Dr. Pacheco, you have any other thoughts, but comments.
No, just other than it's super rare to see like a cutaneous T-cell lymphoma and a cutaneous B-cell
Oh
lymphoma.
yeah, for sure.
Yeah. So I think, Brad's saying we're probably just looking at changing of the phenotype of the existing tumor.
Okay, that's good to know. I believe that studies exist showing overgrowth of certain skin bacteria on those with F, I think it's supposed to be MF. Um, I know that bleach baths can improve the itch, which I assume is because it kills most bacteria on the skin, temporarily both good and bad. Is there a way to repopulate the skin with good bacteria?
Hmm.
Well, this is a good question. I'm going to start out with saying I don't know, right? So this is a whole really exciting field of research on the microbiome. So we all have bacteria, viruses, mites, yeast and fungal elements on our skin, and they're normal, and it's normal to have them. What's not normal is when they overgrow. And it is common in patients with compromised skin barrier. So any Sezary patient, any patient with plaques, patches, or tumors, to have a compromise in the skin barrier and get overgrowth of bacteria or yeast elements, which we then treat often with antibiotics. So it's not uncommon in our clinic to say, oh, I think you need a course of an antibiotic. I think you need a course of an antifungal yeast medication because there is overgrowth. But as far as repopulating with normal, I don't know. I don't have an answer for that.
Yeah, that's a great question. I think more to come. There's lots of researchers looking at kind of maybe we can change the microbiome to benefit and improve outcomes, but I guess TBD.
All right, thank you. Thanks for that tough question. I
Mhm.
have Sezary syndrome. The two main medications I'm hearing about are brentuximab and MOGA. What are the main differences in these medications or reason why a clinician would choose to try one versus the other?
Yeah, so brentuximab is a drug that targets a marker called CD30 on the cancer cells, the mycosis fungoides cells. So it was really studied in a population of patients that had CD30 positive cutaneous T-cell lymphoma on a skin biopsy. There's a little bit, and so it really is focused on those patients based on clinical trial that compared brentuximab to bexarotene or methotrexate, and for people with CD30 positivity, CD30 positive mycosis fungoides, brentuximab's a good option. In that study, patients with Sezary were not included. Um, there is sort of less experience with brentuximab in Sezary syndrome. That doesn't mean that it can't be used, but there is less experience with brentuximab. On the other hand, mogamulizumab is really a drug that it targets a different marker that is universally positive on the Sezary cells and is well studied in Sezary syndrome and is far and away our most effective therapy in Sezary syndrome. So it's hard to be too, I don't know all the details around this particular case. So, but I think most Sezary patients um, will likely get treated with MOGA at some point, unless they respond. Sometimes we'll respond for patients with very low level involvement to things like photopheresis or interferon or some other therapies. But certainly if those therapies don't work, MOGA is usually our go-to option and is a pretty effective therapy.
Okay, thank you so much. And I want to do a time check. We have 10 minutes left, so we still have a few questions in the chat. So if anybody wants to get anyone in the Q&A, please put them in there. Why do long showers or swimming bring out red patches?
I can answer this question. So long showers, hot showers can bring out any skin disease. So it's just increased blood flow to the skin during, a hot shower or swimming, maybe in a warm environment that can bring out and make the skin lesions just look more visible to the eye. So it's a very simple reason on why we see them come out with warm or hot water exposure.
Thank you. Back one more question. If you have hypopigmented MF, that's CD8 positive T, are the malignant clones specific for melanocytes? I know I'm saying that wrong. And that's why you get white patches when the lesions resolve. Would one type of treatment work better for CD8 positive versus CD4 positive?
I'll start with the first question, which is the hypopigmentation. So you can have hyperpigmentation or hypopigmentation in response to any skin disease. So there's inflammation or lymphocytes sitting in the skin. And in this particular individual that's probably asking this question, they may have a darker skin phototype, and therefore the disease is presenting as hypopigmented. It doesn't, I don't think, and I'll let Brett answer, but I don't think it's related to the CD4, CD8 characteristic that was seen on the biopsy.
Yeah, to be honest, we do sometimes see CD8 positive MF in the hypopigmented patients, but I'm not sure if there's actually good sort of epidemiologic information saying that it's more common in hypopigmented MF. So it'd be something I'd have to look into a bit more, but it's a good question. Clinically, it doesn't matter, I suppose, whether it's CD8 or CD4 positive, which is probably the more important message to get across. Kind of goes back to that other comment about gamma delta MF versus the more common alpha beta MF. We don't necessarily think that CD8 positive MF is any better or worse than the more common CD4 positive MF.
All right, thank you. Next question is, will the itching stop when using MOGA? And will MOGA be lifelong?
So the first question, hopefully, the whole, I think hopefully the message is coming across that the treatments for MF are really hopefully geared at improving the itch and improving quality of life. Um, so with treatment, the itch should get better. There are varying degrees of how much the itch may improve with MF, with MOGA, and that's something that we're kind of learning more about. There may be more maybe adjuncts to sort of add to it if we've had some benefit, but not as much benefit as we'd like. But in short, the itch hopefully will improve with treatment, whether that be MOGA or something else. What was the other second part of that question? Sorry.
Will MOGA be lifelong?
Oh, that's a good question. In the clinical trial, it was used until side effects, toxicity issues, or patient decided to come off for whatever reason, or it stopped working. There are certainly patients that take breaks, that take different dosing schedule approaches. There's the real world experience with MOGA is not that there are some people that continued indefinitely because it's causing no side effects and they don't want to stop. But there are some people that can come off therapy or take a break from therapy and then resume it if the disease progresses again. So hopefully, it may be lifelong, but it doesn't necessarily have to be.
All right, I think we have time for two more questions, and they both had to do with light and phototherapy. Can I use natural sunlight on my inner groin and how long? 10 minutes, 20, etc.
This is a conversation that we have frequently with our patients using natural sunlight. So yes, you can use natural sunlight to your skin, including your groin. What we recommend is 10 to 15 minutes per day during peak hours. Peak sunlight hours are between 10 a.m. and 3 p.m. So that was based on a study done to boost vitamin D levels. So you don't need much sunlight to get a systemic effect from phototherapy, which is the reason why you're doing phototherapy. So we have used that data in that study to recommend the 10 to 15 minutes during peak hours of natural sunlight daily.
Okay, thank you. And looks like we probably can squeeze in two more. That was a good. We're kind of trying a lightning round right now. I recently burned during phototherapy after taking a shower. I'm guessing this is because of what you mentioned about increased blood flow. So not shower before, not shower after, any other things to avoid?
So burning with phototherapy is a tough one. So we use protocols to treat patients, or if you have a home unit, you're following a protocol. If you burn, that is a red flag, or if you get significant redness after a treatment, it's usually a sign to go ahead and maybe hold or decrease the treatment by 10% and not go any higher. So the burn is a red flag method, and deserves attention and monitoring and changing the phototherapy dose. As far as the shower, I don't know what to say about that. I don't know how that could affect a sunburn from phototherapy or not.
All right. How often do you see stage MF1B patients progress to more advanced stages, and is there anything that might help reduce the risk?
Yes, good question. It's a great question. So it depends on 1A versus 1B a little bit, but if you're to look at some older studies, around 20% of people progress. But it depends a little bit on the population selected, and um, so that's a fair sort of estimate and what I usually will think about telling people. There aren't clear things to say that you absolutely need to do that'll prevent progression. Uh, although my bias and my opinion is that probably having less cutaneous T-cell lymphoma will probably help prevent it from progressing. So if we can get things in clear remission, it's probably a little bit less likely that you'll progress.
All right, this is going to be our last question. In your experience, what percentage of patients get skin cancer after having multiple phototherapy treatments?
So I'll take this question. So we now use narrow band phototherapy instead of broadband phototherapy or PUVA. So PUVA uses UVA light and goes deeper and definitely causes skin cancers. Broadband uses a range of, UVB light and does cause skin cancer. With narrowband UVB, which we've used for about 25 years, theoretically it should not cause skin cancer, and we rarely see skin cancers. So skin cancers are usually a development from lifelong sun exposure, and not the narrowband UVB.
All right, thank you. So I want to say thank you, Dr. Haverkos and Dr. Pacheco, for being here today and answering all of these questions. It's been really wonderful to have you here live with us. I want to say thank you to everyone that attended the webinar, and we look forward to seeing you at any future programs. And Dr. Haverkos, Dr. Pacheco, do you have any parting thoughts for us, or are you just ready to go on with your day? So
I don't
we
know.
were having a
I
conversation.
think we've got it all out there that I wanted to say. So,
Good, good,
thanks.
wonderful. So thank you again, everybody, and please take our survey, and we will see you at the next Q&A.